Hello, good morning. Thank you first for your very kind invitation, and in particularly to Dr. Al-Fahan, Dr. Malik, and Dr. Fatli. I have to say that after enjoying dinner with you yesterday, I can't believe you have any IBS problems in Kuwait. As you know, functional gastrointestinal disorders are defined on the basis of criteria determined by the Rome Foundation that meets every few years. The last classification is the Rome 4, and IBS was defined as recurrent abdominal pain at least once per week for the last 3 months and associated with altered defecation, changing stool frequency or stool form. The prevalence of IBS is phenomenal worldwide, around 10 to 15%, and the annual direct healthcare is around 1.3 to 2 billion pounds in the UK alone, taking into consideration the prevalence, the chronic nature, and the impact that the symptoms have in the population. And the problem with IBS is that we need to square the circle. We have a difficult task when we manage patients with IBS. On one hand, the Rome Foundation recommends that the diagnosis has to be based on symptoms. We need to avoid unnecessary investigations so we can start treatment as soon as possible. On the other hand, the IBS symptoms, abdominal pain, altered bowel habit, those are very vague symptoms that can be present in multiple conditions, and we are all slightly concerned when we manage patients with IBS, particularly when symptoms are severe, that we're not missing something. And it's therefore extremely important that we have a careful assessment of our patients, very careful clinical history and physical examination, particularly avoiding missing alarm symptoms and red flags. One concept that Rome 4 introduced, which I want to highlight today, is the concept of a multidimensional assessment of patients that allows stratification. It's important that we establish a diagnosis of IBS, but also we need to determine how that condition is affecting the patient's quality of life, because that is going to determine the management from a diagnostic and from a therapeutic point of view. We need to determine the impact of every aspect of the patient's life, if there's any impact on nutrition, if patients have multiple food intolerances, if they are engaging in unhealthful patterns of eating, is there any anxiety, depression that may influence a patient's symptoms, or the comorbidities, functional, rheumatological, or neurological, polypharmacy. And then that is going to help us to, as I say, stratify the patient management. The vast majority are going to suffer mild symptoms, and they can be managed with reassurance, symptom management with appropriate first-line therapies, and some dietetic advice. But some cohort of patients, a small cohort of patients, will have more severe symptoms. They require consideration for neuromodulatory drugs, considering psychological interventions, and more advanced dietetic interventions. And there are patients with very severe symptoms that affect any aspect of their life, impairs tremendously on their quality of life. The management is more complex, requires an MDT approach, and should be managed by experts in the field. So for the majority of patients, what should be the first test that we need to consider? Definitely ruling out celiac disease with appropriate blood tests. Regarding ruling out inflammatory bowel disease, please remember that CRP is more valid, better accuracy than ESR. Fecal calprotectin on a stool sample can also provide a helpful diagnosis of IBS versus IBD. Regarding ruling out infectious causes, there is no point in doing a stool testing for bacterial or viral gastroenteritis in patients that have chronic symptoms, but those with risk factors for giardiasis should benefit from consecutive stool samples. And finally, I want to highlight that there are a number of gynecological conditions that can mimic IBS. Females during the postmenopausal women should be tested with CA-125 to rule out ovarian cancer, and endometriosis can at times be missed in patients with IBS-like symptoms. So we need to take this into consideration. What about colonoscopy? The colonoscopy should be considered in patients that have alarm features, patients over 50 who have a change in bowel habit, particularly females over 50, 60, presenting with diarrhea, to rule out microscopic colitis which can have a normal fecal calprotectin, unlike IBD, and of course, in patients who have raised fecal calprotectin. And this paper that I'm showing in the slide was published just a month ago, involved 12 clinical trials, more than almost 30,000 patients that have been referred for colonoscopy. And patients with IBS or without IBS have similar prevalence of organic disease when the colonoscopy was performed. And the good news was that patients younger than 40 have a very low prevalence as expected of colorectal cancer, and particularly if there were not alarm symptoms. And the prevalence of IBS, and particularly microscopic colitis, was higher on those patients who presented with IBS diarrhea-like symptoms. So we can actually establish what is the risk for our patients and determine if they will benefit from colonoscopy. The other test that we need to consider in patients with diarrhea symptoms is testing for bile malabsorption. And bile malabsorption is quite prevalent in patients with IBS diarrhea and functional diarrhea, established around 15 to 30% of the population. Lack of absorption of biles leads to increased chloride secretion, increased motility, and decreased sodium and water reabsorption, manifesting with diarrhea. And the gold standard diagnosis is using the CCAT scan. And this helps us to establish treatment with bile acid sequestrants. And what about patients with constipation that don't respond to first-line therapies? Well, remember that approximately 30% of patients with functional bowel disorders, they will also have pelvic floor dysfunction in the form of dyssynergia, like anismus, or pelvic organ prolapse, particularly in females who have had multiple pregnancies and vaginal deliveries. And in these patients, we need to consider an MRI proctogram, and as in the slide, you can see that there is an evidence of pelvic organ prolapse with a rectocell and intussusception, and that is going to help to determine the best therapeutic approach from the laxative and bowel returning point of view. Also, there will be, this is very common to suffer with simultaneously constipation and fecal urgency and urge incontinence. And the worst thing that we can do to a patient that has symptoms of urgency is to give oral laxatives to treat their constipation, because they will become even more incontinent. And anorectal manometry can be very helpful to investigate the function of the sphincteric complex. And I personally find transit studies, particularly with radiopaque markers, very helpful as well to establish why my patients might not be responding to the laxative regime. This test involves giving 2 capsules with radiopaque markers on 3 consecutive days and an X-ray on the 6th day. And depending on the number of markers present on the X-ray, we can establish if the patient has a slow transit constipation, and also if he is or not responding to our laxative regime. So I find this actually very helpful. But one important aspect of IBS is that we all recognize, and this is actually the definition in Rome, the recent Rome 4 criteria, that IBS, like other functional GI disorders, are disorders of the brain-gut axis. However, we knowing that the prevalence of psychosocial problems is very high in this population, we feel ill-equipped to start to investigate, to assess the prevalence of anxiety or depression in our population. And I encourage everybody to try as much as possible to review patients' past mental health history, the use of neuromodulation type medication, and if you don't feel comfortable asking questions directed to investigate the possibility of anxiety or depression, there are excellent questionnaires that can be downloaded in PDF format and can be provided to patients to investigate the levels of anxiety or depression. They provide a very, very clear scores that allow us to determine if the patient should be referred to psychiatry, to psychological support, or should be started on neuromodulatory medication. So what is the therapeutic strategy that we need to follow in patients with IBS? First, education and promoting self-management, appropriate dietetic advice depending on the severity of the symptoms, treating the main symptom, what is the main problem this patient has, pain, or which kind of type of bowel habit dysfunction the patient suffers, and considering psychological interventions. And we need to spend time explaining to our patients what is the cause of the symptoms. It's not good enough to say,
your tests are normal, you have nothing, you can go home. The patients have symptoms. We need to explain what are the factors behind the symptoms so they can start to understand those symptoms and implement self-management strategies. We need to explain that patients with IBS have altered gut microbiota, reduced microbiota diversity, that this contributes to low-grade inflammation and visceral hypersensitivity, that there is altered gut motility, for example, increased small bowel and colonic motility, particularly postprandially, and that is associated with the abdominal pain. We need to explain that there are factors like, for example, symptoms after a gastroenteritis or dysbiosis secondary to antibiotics or the presence of bowel malabsorption that can initiate those symptoms, and that there are also external factors, for example, environmental stress, chronic stress, history of early life adverse events, psychological or physical abuse that can increase the risk to develop anxiety, low mood, and we know that patients with anxiety and low mood have increased risk in longitudinal studies to develop altered gut motility, altered gut secretion, visceral hypersensitivity, and those in turn, in association with the low mood and anxiety, will lead to negative emotions, negative cognitions about the symptoms. Patients feel abdominal pain, they become anxious, they feel that they're hopeless, they feel that there is no explanation for the symptoms, and that contributes to perpetuate those. So from the dietetic point of view, what should we be looking for? We need to assess the dietary intake of fiber, fruits, vegetables, fatty food, processed food, identify if there is any food intolerance to lactose, for example, very prevalent in the adult population, gluten or to fructose. Very important to explore if the patient is engaging in unhelpful behaviors around their foods, for example, restricting their meals, skipping meals, reducing size of those, and developing and avoiding restricting eating disorder that I'm afraid is becoming very prevalent in severe forms of functional GI disorders. And we need to promote healthy dietetic routines and increase the consumption of fiber if constipation, but reduce the consumption of insoluble fiber in patients with diarrhea. In those who have more severe symptoms in relation with meals, we can consider low FODMAP diet. That should be done under dietetic support and expertise, and it involves restricting for a short period of time, a few weeks, foods that are difficult to digest by the gastrointestinal tract. Disaccharides like lactose or monosaccharides like fructose and polyols. And these are foods, as I say, that they are very difficult to digest. They are fermented by gut bacteria, causing excessive production of gas. They are osmotically active, attracting water, contributing to gut distension. And in these patients who have visceral hypersensitivity, this leads to symptoms. And there is different trials showing that a low FODMAP diet is associated with improvement in the global IBS symptoms, including particularly abdominal pain and bloating, and reduced production of gas, therefore secondary to reduced fermentation. As mentioned before, in patients with more severe symptoms, disorder pattern of eating can be suffered by those patients, and we need to spot that as soon as possible. And there is a very good correlation between the number of foods that patients perceive as being intolerant to and the severity of the symptoms, and also a very good correlation between that severity and the prevalence of psychosocial problems like anxiety, somaticization, or depression. And not infrequently, patients reduce their foods, as mentioned before, they restrict their diets, they lose weight. That leads to altered gut motility, worsening of symptoms, and we get into a sort of a vicious cycle. In regard to the bowel habits symptoms, which medications can we use for managing diarrhea-like symptoms? We can use loperamide, that's the most commonly used medication for managing IBS diarrhea, but please be aware that it will help stool frequency and stool consistency, but it will not have any effect on abdominal pain. Biliary acid sequestrants like cholestyramine or cholesevelam can be helpful in the context of biliary acid malabsorption. Tricyclic antidepressants like nortriptyline or amitriptyline can be very helpful to reduce abdominal pain. They have an anticholinergic effect, and they help to reduce abdominal pain and spasms, and they are helpful in IBS diarrhea. We also have eluxadoline, which is a mu and a kappa opioid receptor agonist. There's 2 phase 3 clinical trials that confirms the efficacy in IBSD. And some authors also use ondansetron. It's an off-license using IBS diarrhea, it helps to reduce nausea, as you know, it's used in palliative care and in patients with cancer, but also has some constipating effects and can be helpful. Regarding the management of constipation symptoms, we have traditional first-line therapies like soluble fiber that is helpful in a proportion of patients with IBS, but please be aware that can lead to worsening bloating and abdominal pain. Traditional polyethylene glycol, again, is very helpful to improve frequency of bowel movements and stool consistency, but the effect on abdominal pain is unclear and is better tolerated than lactulose. In patients who don't respond to these osmotic and bulk agents, we can consider stimulant laxatives like picosulfate or bisacodyl, but those at times are poorly tolerated because they cause pain. And I personally find small micro enemas or suppositories very helpful in patients who have defecation difficulties or who have coexistent constipation incontinence. Those are really very helpful, and you should take this into consideration. And we have new laxatives, like particularly naclotide, which is licensed for IBS constipation. This is a guanylato cyclase agonist that it works as a secretago, but also reduces abdominal pain because it has an antinociceptive effect. In patients who have problems with the defecation, and particularly if there is evidence of pelvic organ prolapse or defecatory dyssynergia, we can consider bowel retraining, improving the patient's routines around defecation, and it's particularly helpful, as I say, for pelvic floor dyssynergia, but not so much for slow colonic transit. Regarding the use of gut microbiota manipulation, we know that there is reduced microbiota diversity in patients with IBS, with increased number of bacteria that promote inflammation and reduced number of bacteria that have an anti-inflammatory effect. There is a lot of controversy about the use of probiotics, although meta-analysis suggests that they are helpful in a proportion of patients with IBS, particularly those that contain bifidobacterium, which are associated with an improvement of depression and IBS symptoms, and those which contain lactobacillus. And meta-analysis of fecal microbiota transplantation indicates that this is not effective in IBS. Regarding testing for bacterial overgrowth, SIBO is significantly associated with IBS, particularly IBS diarrhea, and the systematic review of using rifaximin in patients with IBS diarrhea shows clinical improvements with a number to treat of around 10, although it's unclear what should be doing on the long term when symptoms recur and bacterial overgrowth is tested positive again. For abdominal pain, we all use anticholinergics, muscle relaxant, antispasmodics to help our patients. And there is excellent meta-analysis showing that with 22 randomized controlled trials discussed in this meta-analysis, comparing antispasmodics with placebo and demonstrating the effect, and particularly for peppermint oil, which is a very safe type of medication to use in these patients. But as I said, please. But as I said, a big proportion of our patients have a history of anxiety, depression. The symptoms of abdominal pain are very intense, affect their quality of life, and we need to get familiarized with the use of neuromodulatory medication. So SSRIs are helpful, particularly in patients who have anxiety and depression, and they can lead to diarrhea, so they are particularly helpful in patients with IBS constipation. On the other hand, tricyclic antidepressants like amitriptyline or imipramine, they are helpful for the management of abdominal pain. They tend to cause a constipation, so we need to consider those in patients with IBS diarrhea. And we'll discuss a little bit in the afternoon about the use of mirtazapine, particularly in patients who have abdominal pain and weight loss and associated nausea and vomiting. And we have to consider the possibility of using psychological therapies. There is multiple trials showing that it's beneficial, particularly cognitive behavioral therapy, mindfulness, gut-focused hypnosis. And if we don't have access to psychological therapy, or we don't have psychologists with expertise in gastropsychology, there are excellent, these days, applications that provide gut-focused hypnosis dedicated to patients with IBS that actually I find very, very helpful in some of my patients. So in summary, and on time, symptoms-based diagnosis and a multidimensional assessment are key principles in the management of IBS. Symptoms severity dictate the additional testing to determine the phenotype of our patients and to target therapy. A biopsychosocial model is recommended, and this again includes appropriate assessment. We need to consider the management, the implementation of appropriate questionnaires and appropriate clinical history taking, and implementation of psychological therapies and neuromodulation. And it's very important to recognize that the severity of symptoms does not invalidate the diagnosis of IBS. If a patient has very severe symptoms of IBS, that doesn't mean that the patient doesn't have IBS, and we need to use every option at our, to help our patients. Thank you. Can I go there?